Good evening, ma'am. Your co-host now, so you can try sharing your slides.
Hi, good evening. Okay, let me try.
Yes.
Okay. Can we see the slides?
Yes, we can.
1 second. So I've put it in presentation mode. Is it okay?
Yes, yes,
Is it moving?
yes, they are.
All right. Perfect. Thank you.
Okay. We'll start the lecture at 7.
Perfect. Thank you.
Hello. Hi, Aparna. You're all set?
I think so.
Yeah, I've just walked in home, so I think we'll start.
Yeah.
So, welcome back, everyone. This is Dr. Sareen here again, and today is the sixth lecture of the course. And you have heard Dr. Aparna Dhar. She earlier talked about is there a role of NGS in solid tumors? And today she will take us through what you see in the NGS report, how do you interpret in different contexts. So I request Dr. Aparna to please start her lecture. Thank you.
All right. Good evening, everybody, and thank you, Dr. Sareen, for having me back here. Just give me a second. All right, so my slides are playing. Yes. Okay, cool. So good evening, everyone. Today is going to be a little bit different. Today we're going to try, we've all heard our speakers over the last couple of days. We've all been discussing NGS, the different, is there a role? We've gone from understanding precision oncology. Is there a role to understanding how next generation sequencing is done, understanding the nuances of the technology? We've understood the bioinformatics pipeline. And today we're actually going to look at the main thing, which is when all of this is done and that report lands up in front of you, how do we interpret it? So for me, when I think of next generation sequencing and these somatic reports, for me, it's like when you learn to read, when you learn a language, you learn the alphabets, right? So it's about learning the alphabets. And then from there, you start, taking those alphabets, putting them together, making words, and start reading them. So when I look at a report like this, for me, it's the way that the cancer is talking to you. And in order for me to learn the language, in order for me to interpret this report, I need to obviously learn the ABCs of this. So for the next 10, 15 minutes, I'm going to walk you through what I think these ABCs mean. I'm going to walk you through, and again, this is not from a textbook. This is just my learning and what I've learned from colleagues, what we've all understood of next generation sequencing and how to interpret these reports. So I'm going to walk you through, help you understand what these ABCs stand for. And after that, I'm going to show you some cases where we've made errors in the clinic and we've been burnt and we've learned our lessons. And then I'm going to show you two very interesting cases and hopefully try and wrap it up. So the first couple of minutes is going to be a little bit theoretical, but bear with me. If you understand this, you're going to enjoy interpreting those reports with me. So let's begin. Let's start with A, actionability. Now, let's start with A, which is the actionability. The first question you should always ask yourself, can this variant be acted upon clinically? A lot of you are practicing clinicians. So when you see that NGS report, look at that variant. In a case of lung cancer, if you see an EGFR exon 19 deletion, you know that this is something targetable. It is on label, which means it's approved therapy. However, if you, let's say, in a case of colon cancer, see a KRAS G12C. Now, in lung, we have a targeted therapy, but we do not have targeted therapy in colon cancer. So before you jump the gun and say, oh, but KRAS is, we have a target, you cannot use that in colorectal cancers, or it's in a clinical trial phase. So always ask yourselves what the indication is it actionable? And more importantly, it's always important to understand just because something is reported in that NGS report, it does not mean it is actionable. Look at your patient's tumor. The second, the biology of the tumor. We know that not all mutations are created equal, and you have to understand which is the driver or which is the passenger mutation, which means we need to understand different cancers. When we look at our lung cancers, we look at our biliary tract cancers, we look at our urothelial cancers, our hepatocellular carcinomas, they're all driven by a gene, which is an oncogenic gene, which we have already discussed in the first lecture. Dr. Sareen has already walked us through oncogenes and tumor suppressor genes. So understanding what gene it is, which class does it come under, is it a known driver for that particular cancer? So a very classical example I like giving is if you see a TP53, it's a tumor suppressor gene. It's omnipresent. It's everywhere. But however, if you see a TP53 and then you see an RB1, that could be the way the tumor is talking to you. That biology could be indicative of a histological change. In prostate, it could be going from adenocarcinoma to a neuroendocrine tumor. In your lung cancers, it could be going from adeno to small cell. So understanding what sort of a gene, what class does it come under? Is it a known driver? Or is it a passenger mutation is extremely important. And in doing this, sometimes I will say we tend to overinterpret. So you'll see TP53, you'll see ATM, KRAS, and you'll see a host of other genes, and we're very tempted to act on it. Take a step back. See, is this something that is synonymous with this cancer? Is this something that is acquired resistance to your treatment option? And then make a decision. So understanding the biology means going back and understanding the molecular landscape of your tumor. Now, I always like giving this example of head and neck cancers. Head and neck cancers have a very different biology. It's not driven by an oncogenic driver. It's actually driven by a series of tumor suppressor genes where they undergo changes. There are various losses of heterozygosity. There are chromosomal losses that happen, which takes the tumor from benign through multiple changes, making it malignant. So if I see in a head and neck cancer a CDKN2A, I tend to see a TP53, a CCNE1, a P10, I'm not very tempted always to act on it, especially upfront, because I know these are the genomic changes that have happened, which has resulted in the tumor. So understand your biology of every cancer is unique. Every subtype is unique. C, clinical context. Now, just because we have a mutation there, we have some therapy which we know is approved, you have to always look at the patient's diagnosis. You want to align with that. What stage, at what treatment history? Look at the clinical course before you actually act on it and say, all right, I'm going to do this treatment. Now, we do know in the era of the whole, trastuzumab deruxtecan, a lot of trials showing that HER2 low, HER2 ultra low, we can treat with this monoclonal antibody. But we also know a HER2 amplification when it presents in gastric cancers is not going to be interpreted the same like in pancreatic. Upfront, if I have a patient with a HER2 amplification, which on IHC I confirm is HER2 low. Vis-a-vis, if I have a gastric cancer with HER2 low, and I'm purposely saying HER2 low and not HER2 positive, I would be more tempted, you as a medical oncologist who's, if there are any med oncs listening to this, you would be more inclined to treat with trastuzumab deruxtecan, maybe upfront also in your gastric cancer, maybe second line, versus incorporating it upfront in your pancreatic cancers. So it is extremely, extremely important to understand, goes back to what I spoke about earlier, and they're going to seem a little repetitive what I'm saying, but the idea is to reiterate certain points, because when we read these reports, we all are guilty of sometimes going a little bit overboard while reading them. So clinical output, look at the patient history, look at the tumor type, look at the subtype, look at the clinical history, response to treatment, and then make a decision if you're going to be acting on that particular mutation. Now, I can't stress enough how important the first one, this D for databases. Just because a lab has said, this is our NGS report, we're gold standard, we're CAP accredited, we're FDA approved, it is not God's truth. Guess what? At the end of the day, while yes, we've got fantastic bioinformatics pipelines, we've got fabulous databases, human errors can happen. So no matter what the lab is, it is very easy. And I'm going to just show you in a bit the various sites that you can do. just punch in that gene and the mutation and actually double check, is it truly pathogenic? CBioportal, your TCGA, they'll actually tell you actionability and with respect to drug sensitivity. OncoKB is another fantastic, is another fantastic database where you can find those genes, the mutation, and it'll even tell you which drug it is sensitive to. So that's very beneficial when we're interpreting these reports, because you're going to make clinical decisions. So time and again, please go in and double check. Another very good one is Jack's Laboratory. A lot of times we do tend to act just because it's come from a particular lab. And I'm going to show you a couple of cases where things have gone wrong. Now, just because something is reported, we have various guidelines in place. Now, when we do germline testing, we have the ACMG guidelines, which are used to help us classify mutations as pathogenic, likely pathogenic, VUSs, and benign, likely benign, and benign. In the case of your somatic testing, first of all, if your NGS report goes ahead and says, as per ACMG, this is pathogenic, so we have reported it on a somatic report, please run in the opposite direction. That is a big no-no. It's such a huge error, because what we use for reporting is important, because based on that reporting, the evidence and the guidelines get set. So with respect to evidence, we have the SCAT scales that we get from ESMO, which actually tells us that for the pathogenic mutation, what level of evidence with respect to therapy is available. Is it tier 1, tier 2? So for example, if you have an ALK fusion in NSCLC, that's standard of care. That's going to be tier 1. But if I have an ERBB2, which is your HER2 in lung, that is tier 2. We do have compelling clinical evidence. Now it's become tier 1. It's become tier 1. However, we do have clinical evidence for this, but it's not synonymous first line for lung. So you have to be very careful. A lot of times what happens is that when they're presenting data in your NGS reports, tier 3 is where you could have clinical data, or you could have it in clinical trials. And they're like, yeah, because it works in pancreatic, so we're going to extrapolate that from pancreatic and say it's going to work in, let's say, it's going to work in a gallbladder cancer. Just because it's somewhere in the same region, it does not mean it's going to work. So you have to be very, very careful with what evidence are they using in one. What guidelines are they using in calling out these variants as being pathogenic? 2, are they following the evidence and guidelines that are set by SCAT in defining what is actionable, what is not actionable? You have to be very careful with that, because if you're making clinical decisions, especially if you're doing something out of the box, you darn well better make sure that you have enough evidence backing you, even if it's in a clinical trial, because the lines can get very, very blurry when they are reporting these. Then we have F for frequency. How many times I've had this question asked about variant allele frequency. So variant allele frequency, in the most basic way of understanding, is that how much percent in that particular tumor sample or in that ctDNA sample does that mutation exist. So it's usually it's usually as a percentage. So we tend to see this. You will see variant allele frequency, mutation allele frequency. These are just some of the language that they tend to use to explain this. Now, sometimes what we tend to see in our NGS reports, so for example, in a hormone-positive breast cancer patient, first line of treatment you've done an NGS for whatever reason, and what you've picked up is at baseline, you've maybe picked up an ESR1 mutation. Now, this ESR1 mutation could be sitting at a VAF as low as, let's say, 0.01%. That 0.01% is a subclone. It's a known resistance mechanism that is getting ready to get activated eventually post-treatment, but that resistance mechanism is lurking around. And in some cases, we should not be missing those subclones, which are sitting at those really low percentages, because a lot of times they can potentially be emerging resistance mechanisms that we tend to miss out on. Like I said, it's the tumor talking to you. It is the tumor telling you, you give me this drug, I have a backup plan ready to be resistant. So remember that when you are doing your NGS and you see those low VAFs and you go like, these are just useless. They're passengers. We don't need it. Let's just look at the main, the main drivers. Let's look for the PIK3CA. Let's look for the EGFR. Let's look for the ALK. Don't disregard those little clones that are sitting there, because it's that little clone that can actually wreak havoc. Then also, like I said, the tumor's talking to you. If we look at VAFs, if we see a variant allele frequency on tissue, on liquid, greater than 35%, and if that particular mutation, like BRCA1, ATM, BALB2, some of your Lynch genes, if that particular mutation is also a known germline event, how do you find out if it's a germline event? You put it into ClinVar, you put it into these various databases, and you check, is this also a known germline mutation? If it is a known germline mutation, you're seeing a high VAF, then I very, very strongly recommend do Sanger sequencing, get this tested to ensure that this could be a potential germline mutation. So reading these, you have to be very, very careful. Look at those percentages, they are important. Now, I do often get a question that because the VAF is high for a particular gene, does that tell me if that's my dominant clone? Not always. You can't take it as a rule of thumb that just because the VAF is high in this particular gene, so that's my driver. It could be another, the driver can also be sitting at a far more lower percentage, and that's the one that could be the one actually driving the tumor. Now, is there a straightforward answer how to do that? No, it always boils down to B for biology, understanding the clinical treatment plan that the patient has, and that will sometimes help you understand how to interpret these mutations. So, my slides are moving. 1 second. Oh, here you go. So just coming back to what we spoke about databases, these are some of the databases that are available. So don't always rely on what the NGS says. Always check, double check, quadruple check, infinity times check before you make any clinical decisions on an NGS report. And if you can't use any of this, guess what? Dr. Google can help you. And this is again from the ESMO guidelines where they themselves are recommending it. So it's not just me. This is what I use in my clinic. But in addition to that, this is also recommended by ESMO, some of these databases. Now, germline alerts. In the era of, HRR testing, somatic testing, ovarian, prostate, pancreatic cancers, they're very, very, even breast cancers now, we're very tempted, especially in the clinic, patient is not going to go again and again for testing. So the thing is, okay, let's do somatic testing. And if that somatic testing picks up a mutation, which could be potentially germline, then we'll see. While the thought process is right, we forget counseling the patient. And the patient suddenly presents to the clinic and is happy the NGS report has picked up something, because guess what? Treatment is an option. There is a therapeutic option. And then you drop this bomb on them. Oh, by the way, we found a mutation and it could be potentially hereditary. So a lot of patients go in blind, not knowing about it. And then suddenly this comes. You as a treating physician are obviously rattled by it. You are upset because then you have to break that information. You cannot not share that information because guess what? There are implications for further cancer risk for the rest of the family. So it becomes a little bit difficult at that point to bring it up. So time and again, I can't stress how important it is. Don't shy away from those potential germline mutations, potential germline events that can be picked up on that NGS report. It is a very, very difficult conversation to have with your patient. And trust me, as someone who sees this time and again at the clinic, as a genetic counselor, there are some days it is so difficult breaking that news to that patient because you can't look the other way and the patient is not ready for that news either. So please upfront, do share this information that there is a possibility that we could pick up something that could be potentially hereditary, for which we have to confirm later. Ignoring this is, I deal with it in the clinic, and trust me, I could tell you guys stories. I could write a book with some of the events that happen in the clinic because patients were not pre-counseled for the somatic testing. Now, histology and heterogeneity. A question I very often get asked, that if I do NGS, do I really need to do a biopsy? The NGS will tell me. No. The NGS for somatic testing will not tell you that. Yes, certain genes are, certain molecular profiles are synonymous with certain cancers, but that's not going to confirm it. We know it's synonymous because there has to be a histological correlation. When somebody sends me an NGS report, my first question is going to be, what's the cancer type? What's the subtype? Histopathology. If you just tell me it's lung, I'm not going to know what to do with it. It's as simple as that. If I've got lung sitting in front of me, I need to know, is it adenocarcinoma? Is it squamous? Is it small cell? What is happening? What sort of a tumor am I dealing with? Is it pancreatic? Is it, because my treatment recommendations are going to be based on that. So always, always understand the histology, the histopathology, what type of a cancer it is so very important. Now, there is also what we call intertumoral and intratumoral heterogeneity. Now, I did briefly talk about this in my previous talk. We know majority of our cancers are heterogeneous. So what happens is when we start treating these cancers, one, at baseline, there could be multiple mutations and multiple genes that could be causing the disease. And sometimes along the way, as acquired resistance to our treatment, and especially those heavily pretreated patients, a lot of this can be picked up. You know, a lot of these mutations can be picked up as the tumor progresses. So what you'll start seeing is from the primary site, sometimes even within the tumor, between different sites, you are going to see a difference in the molecular profiling. And there are a lot of case studies, reports that have actually highlighted that they've taken a patient's sample, metastatic disease, that one liver sample, they cut it into 8 different quadrants, 8 different, mini, 8 different quadrants were set for NGS. And they did see discordance. Now imagine it's that one biopsy sample, but from 8 different places, they did separate NGS. And they did see intertumoral and obviously intratumoral heterogeneity. So suddenly you do an NGS and you say, where did this mutation come from? It wasn't there. Why is there discordance between my tissue and my liquid? Something is wrong. Not necessary. Tissue testing, especially ctDNA testing, can help pick up these, and can help address the heterogeneity issue. But more important, it can pick up all the various mutations that could be lurking around. So understanding the histology is very, very important. But one thing I will say is that a lot of times we tend to overcall the discordance. We tend to get very hyper that, why was the IDH1 picked up over here and not picked up over there? The VAF is low. Is this subclonal? Is this something that will create a problem going forward? Don't overread an NGS report too. Sometimes there is a lot there, and some things are more like, for lack of a better word, fluff. So I do know you're like, okay, it's IDH1. Why am I seeing IDH1 in lung cancer? Is this a resistance mechanism? Is some other pathway activated? Has my patient's tumor, suddenly found a new bypass mechanism? Maybe not. Maybe that IDH1 just thought, everybody's, doing this whole cause. Let me just join along and be a part of the pathway. So you have to be a little careful that just because of, oh, this could be heterogeneity, I've picked up something new. Be a little careful that if you see IDH1 in lung, it's really not doing much. It's just some random gene that's, it's just something random that is possibly picked up and has come in over here. Versus IDH1, if I tend to see, let's say in my glioblastomas, I know I need to take it a little bit more seriously. Now, let's talk about I for immuno-oncology. In the era of precision oncology, you cannot not talk about immunotherapy. And we use 3 markers for it. One is your PD-L1, which is an IHC. I'm not going to be talking about that. But let's talk about MSI and TMB. Now, if the MSI is high, I know these are agnostic markers. You can push back and say they're agnostic markers. It doesn't make a difference. It does make a difference. So MSI high in colorectal cancer is no brainer. you give pembrolizumab irrespective of the line. But if it's an MSI high, let's say in breast cancer, you're maybe going to stick more to your standard of care before you consider doing MSI testing, before you consider, immunotherapy. So it varies. It does not work for all tumors. So you have to obviously go back, look at the data, but we do know these little distinctions are there. So when you see that on the NGS report, look at your tumor type. Now, another huge, if I could say, issue, for lack of a better word, that we tend to see here is with tumor mutation burden. So let's understand tumor mutation burden. The basic concept is you're measuring the number of somatic aberrations that are happening in that particular tumor. And as per the studies, as per the Keynote 158 trial, what they said is if anybody has any tumor has 10 mutations per megabase or higher, that individual is TMB high, that individual's tumor, is TMB high, which means they'll respond to immunotherapy. Okay, now, one of the biggest misconceptions that we have here is we think that just because it's high, it's going to give you that neoantigen load, which in turn your treatment, your tumor is going to respond to your immunotherapy. We know time and again, every cancer is different. The mutation, the neoantigen load may be different, so the cutoffs have to be different. One size fits all does not work. And what further adds to it is that these studies were done on one international panel, which was the Foundation Medicine panel. After that, a lot of individuals came out with their own, tumor mutation burden panel. They all came out with their own panels, different assays, different cutoffs. And because there is no synchronity between them, there's actually a very, very nice study. I'm going to I think I've kept it, where they took a patient's sample, and they took some 45, 48 patient samples, and they sent it to 10 different laboratories to measure the tumor mutation burden, non-FDA approved lab. These were, assays that were designed in the laboratory. So these were LDTs. And it was amazing as to how everybody had a different cutoff and had a very different number. So how do you treat based on that? So one of the biggest errors and one of the biggest problems we tend to face when we do this NGS CGP report, we tend to see TMB. Don't get excited on seeing a TMB high. Look at the tumor type. Look at the assay. Even between international partners, it's not the same. A 10 mutation per megabase on a foundation report is not the same, and it does not have the same implications than, let's say, on a Guardant or a Tempest or a Caris or any of our Indian domestic partners. Tread with caution when we're doing immunotherapy-based decision, making immunotherapy-based decisions on your TMB, and especially your TMB. MSI, you just have to be careful of the tumor type. So this goes back to I always use this picture for germline testing. Don't be the ostrich by putting your head in to avoid a conflict. Please, upfront, counsel your patient so that you don't end up being that ostrich and putting your head in. I know we need to do the NGS upfront, therapeutic implications, but please, please don't shy away from this. It's a very difficult conversation to have. Now, junk or jewel. There are different noise that we see from so one, a lot of times when we see reports, we tend to see a lot of mutations. And a lot of times in seeing a lot of these mutations, we get very confused. A lot of times, TP53, you're seeing DNMT3A, you're seeing KRAS mutations, you're seeing just random, and you tend to see a series and pages of it in some of these NGS reports. And so many of them are VUSs. Some of them you don't even understand what they're doing over there. And there's so much noise. Forget about the raw data which comes out and which they, I guess, copy-pasted, put on your NGS report. But when you look at that NGS report, it can be very overwhelming and frustrating. So you need to go in and understand what is junk and what is technically a jewel. Junk would be your VUSs. Just ignore them. Just plant them aside. And I know certain labs where they do these big NGS, these big NGS panels, you get 10, 12 pages of VUSs. Ignore it. Just ignore it. Don't look at it. Then when you're doing liquid biopsies, we tend to see something called CHIP. CHIP, like I mentioned last time, are clonal hematopoiesis of indeterminate potential, which means, in very simple terms, when you're doing a liquid biopsy, you're essentially looking for the cancer cells' discarded garbage, which is the somatic DNA, which is what you're picking up. Now, while the dump truck comes and picks up all the somatic DNA, which the cancer has discarded, sometimes it also has those discarded WBCs, it has those discarded lymphocytes, sorry, especially in your smokers, in your older individuals who are also dumping their genomic garbage in. And sometimes that gets picked up. And if you don't have a good bioinformatics pipeline, and this goes back to who your laboratory is and their pipelines, a lot of times, a lot of these mutations that are actually not to be reported, they're of indeterminate potential, they don't belong to the cancer, gets reported. So we tend to see your DNMT3A, which is one of the most common ones that comes in. You tend to see TP53, KRAS. So be a little careful. Now, if I see an EGFR over there, I know EGFR is not going to be one of my CHIP mutations, but in some cases, if you are seeing it at very low VAFs, you will be able to identify them as 0.01%, 0.03%. Please ensure that this is truly, is it junk or is it something actionable? But most of the time, if it's not from a good lab, especially, you will tend to see a lot of this. So you really need to go in and start looking and being very, very careful. You need to know how to sort it out. Okay, known resistances. Now, every time a patient progresses, we do try and understand why is this happening? And it could be because of known resistance mechanisms. So when we're looking at NGS reports, when we are reading, this is why understanding the clinical history is important. If I know my patient has been on, let's say, crizotinib, I do know that there is a possibility that on that ALK EML4 fusion, my patient could have acquired an ALK G1202R mutation. It's a point mutation, which is a common resistance mutation, which means I'm going to switch therapy and move to lorlatinib. So understanding that what is my baseline mutation or what was my baseline therapy, and then from there making clinical decisions, you have to look for these resistance mechanisms, and they're there in plain sight. So understanding and reading this becomes very, very important in knowing who are your resistance mutations. And again, this you can do with a good PubMed search, punch that mutation in, and you will get your information. Now, not every panel is the same. And, I was at a meeting recently and it was quite shocking that, it was like, I did testing, but I did NGS. And the argument was like, I did NGS. And I was like, yeah, but what panel did you do? Did you do a hotspot panel? Did you do a full gene panel? Did you do a 5 gene, 100 gene? All NGSs are not the same. So back in the day, I'm going to just quickly come here. Okay. So back in the day, it was very easy. We would do IHC, RT-PCRs and all. But now we know that we're wasting a lot of DNA. We're wasting a lot of tumor, especially tumor. So what we've started doing is we have gone into dividing our panels, and this is just my rough understanding. It's not like the most perfect thing, but yes, we do have those one specific gene panels, and this is usually more when we're doing Sanger sequencing and you're looking for that particular point mutation. Seldom I have used it in somatic testing. Maybe if I'm looking to confirm, because the quality of the NGS wasn't good and I'm looking to confirm a particular mutation like an ESR1 or an RB1, or I'm looking for one of those resistance mutations that I'm genuinely not sure if this was covered right in the NGS report, then maybe I would repeat it as a single gene test. Otherwise, it's rarely used. What we tend to use are more specifically organ-specific panels. Organ-specific panels are those panels that have genes that are frequently mutated in that particular cancer type, but they don't always do full gene analysis, which means they look at hotspots. Hotspots means those frequently mutated areas in the gene, frequently mutated, frequently mutated exons that we tend to see in those particular genes, it's only that's looked for. So what you end up doing is you tend to miss out on novel mutations for where you could potentially use an action, where you could use targeted therapies. Now, this is usually done in a cost-constrained environment. In some panels, they do RNA with it, but usually it is DNA. So why do I want RNA? Because for my fusions, my NTRACs, my RET, my ALK, it is extremely important that for all these fusions, we do RNA NGS with DNA and not just DNA-based NGS. Now, we do have small panels too, the 50 gene. This is usually what a lot of people are very comfortable doing. These can be, it varies from laboratory. Sometimes they do full gene and sometimes they do hotspots. So tread with caution. You have medium, which is a panel I tend to like using in a cost-constrained environment because around 70, 100 genes. I get MSI, I get my copy numbers. And it's usually with RNAs. So I'm kind of comfortable, making, for treatment decisions based on something like this, because most of my resistance mechanisms and all are covered. In an ideal environment where cost is not an issue, I think all of us can agree we love going ahead and doing CGP, where we get a complete 360-degree view. We look at all the genomic instability markers, various genomic assays, and we're looking at anything and everything that you can report with respect to the gene. Now, one thing, if you'll realize, is I did not put TMB in the 100 in my large panel. I put it in my extra large panel. So as per the AMP-CAP guidelines, in order to report TMB, it has to be done on a minimum 250 gene panel. Ideally, it should be an exome that is done. But because of cost constraints, a lot of times we tend to do it on a minimum 250 gene panel. So these are the somatic panels that are available, and it's important knowing what you are testing for or what your patient has tested. So when you get that NGS report, go to test methodology and look at the gene list and understand what has your patient tested for before we make any assumptions and presumptions. This is, again, just reiterating the difference between CGP and hotspots. So these are some of the factors you should consider choosing. There are a lot of laboratories that are available. Everybody is great. So just because somebody is CAP, clear, accredited, that's not the question. You need to first ask yourself, do I really need to do CGP testing? Look, I love it. I'm biased because I want to look at everything. But honestly, in the clinic, if you've got a melanoma case, do you really think it's needed to do CGP at that point upfront? PD-L1 negative, we do know around 60% could have a BRAF V600E or one of the BRAF V600Ks. Why would I do a CGP, right? So the question you need to ask as clinicians is, what's going to work better for my patient? What testing is required? And apart from what testing is required, if I'm looking just for a BRAF V600E, I can do a simple RT-PCR. Do I really need to do a next generation sequencing? If I want to look at the HER2 level, I know I need IHC. Why do I need to do NGS? So ask yourself this question: what are you looking for? Why are you doing this before writing an NGS test? Choice of laboratory. Accreditation, approvals, yes, it is important, but the validation and the process robustness, I can't stress enough how important this is. The depth of coverage, is it sitting at, if you are reporting tissue testing on 100x run in the opposite direction, that's a poor quality report. Ideally, you need 500x, but in India, our domestic partners, due to cost, obviously patients aren't going to pay for that. So a lot of times they bring it down to 250x. Anything less than that, run in the opposite direction. Ask for validation data. Have they published their validation in any reputed peer journal review? Very important. Don't just have a lab come and say, but we do 500 gene panels and we do 50,000 genes and we do, we do this and we do that and we use AI. Don't get swayed with that. Ask for validation. And if you can't read those validation reports, please befriend a molecular oncologist, a precision oncologist, a molecular pathologist, and have them assess it for you. Have people like them on your speed dial. It will be super beneficial for you for making clinical decisions. Now, ask with respect to the bioinformatics pipelines. I have spoken about it earlier. If you don't have good bioinformatics pipelines, you are good. And I think we had a fantastic talk yesterday too by Dr. Pratik. You are going to land up in a soup. So please ask about the bioinformatics pipelines. What databases are they using? Do they have their own internal databases too? Because that can also be beneficial. Get an understanding of all of that before we go ahead and just consider, switching the laboratory. Very simple example. I'm sorry, it's a little fuzzy. I can't find my original report, but this was essentially an NGS that was done in a lung cancer case. And this is not NGS, sorry. We did EGFR testing, RT-PCR. Back in the day, there used to be BioCartis was one of the approved platforms. So it came back negative, no EGFR present. This patient did not want to undergo chemotherapy, so came back to the clinic, and we did another test. We did a liquid biopsy, coincidentally. And if you see over here, we found this particular mutation. It is the exon 19 deletion, but the codon is very different from the exon 19 deletion, which is the 745 that the IDELA test was doing. So understanding the test, the methodology is very, very important when you are interpreting a report. If you would have just crossed it out and said, no, everything was covered, we were losing out a potential EGFR mutation. And it's not that the tissue missed it. It's just that the tissue did not have this particular mutation in its assay for testing. Now, this is what I was talking about, the genotyping errors that we tend to see. So this is an EGFR where they saw discordance between multiple labs with respect to reporting. So if EGFR back in the day was an issue, now I know we've rectified it. You can imagine what would be happening with say, a TMB. Again, with the panel, I'm going to reiterate this, and I sound like a broken down tape recorder most of the time, but I cannot stress enough how important RNA sequencing is in today's day and age. This was a fantastic retrospective study, which was done at the Memorial Sloan Kettering Group. And what they saw was that retrospectively, those lung cancer patients that had tested negative for an actionable biomarker, an oncogenic driver, when they ran those same cases on RNA sequencing, in 14% of them, they realized they'd actually missed out on these fusions. Imagine 14, that's a huge amount of patients that could have benefited from targeted therapies. So again, I'll repeat, look at your test methodology. Sometimes what you'll see is total nucleic assay is done, which means they've done DNA and RNA. So sometimes the language can differ, but usually the labs, a good laboratory will have it in their test methodology if they've done DNA or RNA sequencing. Now, let's move to M mutations. You are going to see multiple mutations. And we've seen this, we've seen so many of them happen over there. And then we look at them and we get lost and you get bamboozled and you're like, okay, what's actionable, what's not? Don't get overwhelmed by it. You are going to see multiple mutations. Some of them co-occur together. Some of them are actionable. Some of them are just telling you that, hey, this pathway has been activated because the other pathway is instigating. I always give this example of APC KRAS that we tend to see in colorectal cancer patients. KRAS we know is synonymous with colorectal, but do you know who's actually instigating it? And I'm using funny words. I know these are not medical, but think of it in this sense that APC is actually the main person who's sitting over there, who's part of the WNT, the beta-catenin, the WNT signaling pathway. It gets activated. That's where it's coming from. And what it does is because of the crosstalk that happens between pathways, when APC gets activated, it goes and further activates your KRAS. So if I want to actually shut my KRAS down, I need to first stop the loudspeaker, which is APC, which is actually going ahead and telling KRAS, all right, get activated, get more aggressive. So sometimes understanding the crosstalk between these different pathways is what you want to look for. Look for clues. And honestly, when I'm interpreting, I keep the pathways open in front of me. I keep a picture because guess what? We're not going to remember everything or we can forget. And then start looking what sort of interplay can happen before you make a decision and say, okay, fine, I'm going to go ahead and act on this. So another thing, like when I say that co-occurring mutations, you'll see PIK3CA, you'll see PTEN lost together. We know they're part of the PI3K-mTOR pathway. So maybe if you give a PI3K inhibitor or an mTOR inhibitor, you shut this whole thing down. So don't make the error of focusing on one mutation. Look at the rest. Obviously, while doing that, you're removing your chips, you're removing your VUSs, you are correlating to the biology of the tumor, the clinical history of the patient, the comorbidities of the patient when you're making these decisions, but you're looking at everything. N is for nomenclature. Now, different laboratories sometimes tend to stray away from what the standard of care and what the recommendation is with respect to AMP-CAP guidelines. So a very classical thing is that we see for EGFR, if you realize I use a lot of lung because I think that's something we're all very familiar with. So I'm going to be using a lot of lung-based examples. So in EGFR, we have a protein change, which is E747, and there's a deletion of between E747 and A750, right? So this is your classical exon 19 deletion. And it's very standard labeling, but sometimes because of the way the mutations are written. So I had a recent one where they had MET, and then they said 13-15 fusion. This should be reported as MET exon 14 skipping mutation. But sometimes because of how the language is, in one place it's written MET exon 14 skipping, but in the other place what they've written is, MET, exon 13-15 fusion, it can get very confusing. So stick to one terminology, one nomenclature throughout the entire report. Always double check these annotations. Go back into your databases and actually check. Sometimes there can be errors in this too. So be careful. That's why it goes back to D, databases. Always go back and double check. Now, O is for overlap with other tumors. And while we tend to see HER2 amplifications, not point mutations, HER2 amplifications, which are synonymous in breast, we cannot use the same thing in lung. In lung, I have for exon 20 insertions, I have data. We're now seeing emerging data with respect to data from one to the other and just say that you can't copy paste evidence from one tumor type to another. So you have to, and if you are going to do it with caution, but definitely not upfront, and not because the NGS report said it, so we have to do it. Look, I'll end up repeating myself again, but look at A, B, C, D, till what we've learned till now. Look at the alphabets again and see, do we really have to go back and implement this again? The P is for pathway mapping, and I always love keeping my pathways open in front of me, circling and saying, okay, so when you take an NGS report and you look at the gene, start writing next to it, which pathway is it a part of? Then look at that schematic diagram and do a cross-reference. Is there some interaction somewhere? Are 2-3 genes part of the same pathway? Are 2-3 pathways, responsible for a particular activity? Is it for survival? Is it for growth? Is it for apoptosis? What is the end result of that particular pathway? Start mapping them. It is really, really important to understand. Don't read them in isolation. See who is connected where. Writing it down is always a brilliant way of doing it. I still do this. It's been 20 years since I'm doing this, and I can't tell you how beneficial I find it that even today I will sit down with my NGS report and I'll say, okay, which mutation is this? BRAF. Where is this BRAF mutation? It is in the MAP kinase pathway. Great. What comes after that? And then I'll go through the whole pathway and I'll understand. So always, always go back, look at these pathways, look at the crosstalk. Take some time here. Q is for quality metrics. Now, we've already discussed this a little bit earlier, where we're looking at the depth of coverage. We're talking about the validation. We're looking at the QC filters that the laboratories have. And if they are over-interpreting what we tend to call weak calls, where there's that, sometimes a doubt and the quality is poor also, they say, yeah, okay, we'll just take it as positive. It's lung, it looks like an EGFR, let's just report it. They should not be doing that. So look out for some of those weak calls. Usually, laboratories do put a note, but sometimes, unfortunately, we do have errors happening. R is for the reporting style, and I'm going to show you what a good report entails. So we do have the databases that are in place, that is for sure, but we also have various tiers based on the AMP-CAP guidelines. So everything should be very clearly reported in these NGS reports. So like I said, it is AMP-CAP guidelines. So we do have tier 1, 2, 3, 4. And it's very clear, again, on this based on the level of evidence. Is it level 1A, level, is it level 1A or level 1AB, level 1B evidence? All of this is very categorically stated as to what classifies as that. It is important that this is followed. This is very similar to the SCAT guidelines, which ESMO also has, and this is what we use in interpretation and making therapeutic recommendations. Now, a lot of times we are very tempted with VUSs that no, but there is this, there is a resistance mechanism. It looks like this is something that is actionable. It is, I've seen my patient is not responding to a CDK4/6 inhibitor, and there's a VUS RB1, so it has to be it. No, it doesn't. So do not, the same way in Germline, how we say, do not act on a variant of uncertain significance, no clinical decisions to be made. Similarly, in somatic, do not act on them. But what's very interesting in somatic, which I found interesting, was that huge percent of them, they do get reclassified from being VUSs to becoming pathogenic, which I thought was a very, very interesting phenomena. And I guess there's more functional studies happening here versus the others. So again, this is just, if anybody was interested, they can take a snapshot of what these different tiers mean with respect to treatment options. Now, these are some of the vocabulary that we do tend to see in our NGS report. So when we're looking at a somatic NGS report, for me, these are some of the parameters I look at to see how good, bad, ugly this NGS report is. Obviously, the guidelines. Like I said earlier, over here, this is obviously taking everything into account. But if it is somatic, and if someone has reported a mutation based on ACMG, like I said earlier, run in the opposite direction. The laboratory has a major quality issue. If it is a AMP-CAP guidelines, that's what we use for somatic reporting. They should be telling you the copy numbers, how many copy number reads there are, what type of a mutation is it? Is it a deletion? Is it a duplication? It is an insertion. All of these make a difference. Is it a fusion? Because I know in a fusion of an NTRK, if the partner is right, if the fusion partner is right, I can give therapeutic agents. But if it's an NTRK point mutation, it could be a resistance mechanism. And most of the time, it is a resistance mechanism, which means my drug of larotrectinib and entrectinib may not work. So you have to be very, very careful. So the laboratory has to very categorically state what sort of a mutation is it. And obviously, the variant allele frequency should be mentioned over there. Now, in addition to that, when we are doing this, obviously, you need the demographics of the patient, which is the patient's name, the patient's age. There should be unique identifiers which can help us understand which case this is. But the specimen that they've used for testing, was this a liquid biopsy? So when was the sample collected? If it's a liquid biopsy, what is the tumor fraction? It is so important to know in that blood sample what was the content of tumor, because if it is a low tumor fraction, you could be having false positives and false negatives. So you have to have that percentage written up there. Tumor fraction of this sample was so much. And every laboratory has a different cutoff, but I think anything greater than 1% should suffice. Some people say 4%. It again boils down to what your laboratory and what the laboratory's validation data. Then if you're doing tumor testing, you should know where the biopsy site is. So for example, if it's a bone biopsy, we know it undergoes decalcification. So when I'm doing my DNA extraction, there can be degradation. There can be errors in that NGS reporting. So it is important to know the biopsy site and the tumor content. So if it's sitting at 30–40% tumor, great. Some laboratories can report as low as 5 to 10%, but again, you want to go back, look at their validation data before you accept reporting on a 5%, 10% tumor. The results, obviously the test name should also be written, what sort of a test name and what platform they've used. So all of this should be mentioned up front. In addition, you should have the results written very clearly, very categorically. It should be very, very, when you look at it, you should be able to understand this is the gene, this is the codon, this is the protein change. It's in this particular exon. If it's germline, obviously you'll have the heterozygous, homozygous zygosity coming in. We don't have that in somatic reports. So if someone puts that in the somatic report, and I'm mentioning this because I'm seeing this in somatic reports, we don't mention zygosity in it. So all of this, and the VAF should be very clearly mentioned, and the type of mutation is it, and the level of evidence. So on the first page for the particular mutation or mutations, everything should be there. It should be in a very clean, clear, usually it's in a tabular form, so it's easy to pick up. Now, in the comments section, if they are putting recommendation treatment, if they are saying something, if a particular mutation is pathogenic, the PMID number, the ClinVar number, OncoKB, whatever databases they've used to confirm that this is a pathogenic disease-causing event, something that is actionable, that data, those references should be very, very, categorically mentioned on the report. So usually what you'll see in a good NGS report, on the first page, it's a summary. On the second page, each gene is going to be broken down. Every mutation they've reported is going to have some sort of a summary with it, explaining why they've called it pathogenic, explaining why they've made the recommendation with evidence. And I've purposely not used a particular laboratory here, but just giving you a fair idea as to how everything should be very categorically and very neatly labeled. So like you see, this is a case of lung cancer. They have mentioned the name of the diagnosis, the biopsy specimen. If you see, they've not written where they've taken the specimen from, but it should, the biopsy site should be written. What is the tumor content? 70% is good. They've spoken about the methodology, the databases they have used, the genes they have tested for, and again, what form they've tested on. And if you look at these results, they've given you the name of the gene, what is the variant change? They've stuck to the same nomenclature everywhere. You have this reference sequence over here. You've got the VAF, you've got the level of evidence, you've got the drugs mentioned here. That is again based on the level of evidence. And I know in a case like this, my patient has an EGFR mutation. They're going to be treated with anti-EGFR therapy. But this report is also telling me one more thing, which is here there is an amplification of a MET, which is a known resistance to osimertinib. So I'm going to be looking out for my patient and, religiously following up with respect to treatment, maybe keeping them on a slightly more tighter leash versus what they would have, versus what would be done if there was no MET amplification. And you see how the copy number is very clearly mentioned here. So I know this is of significance. This is what a good NGS report should look like. Now, these are just some of the labs that I've just put here. So if you see up here is the liquid biopsy. They've told me when they've collected the sample, when they've reported. In liquid biopsies, we tend to repeat a sample multiple times. So they've written which test number is this, the report type, the sample and identifier, everything is written. Similarly, over here with respect to tissue testing, where was the biopsy site? This was a case of a carcinoma of unknown primary. We're taking it from liver, the specimen type. All of this is very, very nicely mentioned. And up here is just here we just got a Germline report, a Germline one showing the demographics. So it's very beautifully written. This is what I just kept it here just to give you an idea, but this is like with respect to a Germline. This was a BRCA2 pathogenic, and look how very nicely they mentioned why is it pathogenic. So very similarly, this should also be followed for your somatic testing. Then we come to S, which is subclonality. Now, I spoke about this earlier, that based on the VAFs, sometimes these can be clones, resistance clones, which are emerging, getting ready to create a problem going forward. So that's the ammunition the cancer has to resist your treatment. Or sometimes there's really, really small mutations that could be sitting there, or they could be large based on the percentage. So again, don't let the VAF always decide. Is it resistance? Is it dominant? Look at the cancer type and then make those decisions, but do not ignore subclonality. It is one area which I think we all struggle with and we tend to miss out on, but that is the way the cancer is talking to you and actually telling you that, hey, I do have a resistance mechanism in place, or hey, the biology is going to change, the histology is going to change. So be on the lookout for these and don't let the VAF percentages always mislead you. Make decisions. VAF is important, but not the decider of is it subclonal, is it passenger, is it driver. T is obviously our therapeutic targets. We have your experimentals, you have your on targets. I think we all are very, very familiar with this, but when you're interpreting an NGS report, we need to know, are we using targeted therapy? Are we using off-label, on-label, or are we actually doing combination therapies, which may be in clinical trials or just something we are interpreting based on our own, just by looking at the crosstalk of pathways and saying, okay, if I shut this pathway down with an mTOR inhibitor and I give CDK4/6 over here because there is a cell cycle pathway activated. So when you're doing all of this, that is trial and error, which can happen in our clinic. And today with precision oncology, we tend to do a lot of this in our clinic. So just tread with caution and be careful as to what sort of drugs these are. And obviously toxicities are there, but don't get carried away in just kind of saying, okay, I'm going to do 1, 2, 3, 4, 5, 6 drugs put together. It's a patient at the end of the day, not a test subject. So be a little careful. Don't always get swayed away with NGS reports showing, oh, this targeted therapy here, 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 here. Don't do that. It goes back to from A to S, what we've learned. Look at all those factors before you say it's targeted, let's act. Now, U is basically your variance of uncertain significance. Don't act on something for which we don't have clinical evidence. I think we talk about it every time, everywhere. Do not act on it. V is for validation. Sometimes, especially with our HER2s, if I see a high amplification, HER2 amplification, or I see it sitting at 5, 6. So first of all, the cutoff is anytime the copy numbers are greater than 6, we call it actionable. If it's less than 6, if it's between 5 and 3, it's medium, and any of that. So for a copy number to be high, for it to be actionable, it should ideally be over 6. Now, sometimes we have our doubts, especially with HER2. So we use orthogonal methods to confirm. Sometimes you could have a FISH. We bring in FISH when we want to confirm a MET exon 14 because the fusion reads were very low, but we have a doubt. So we run that. Sometimes we do it with ALK. Sometimes we do it with MET. So if at times you are not sure if that is a true mutation, the reads are low, then in a case like that, I would consider using an orthogonal method. Sometimes your EGFR can also come low. So you do an RT-PCR just to confirm is this truly a T790M. So validating your results sometimes is required, even with those, even with those really, really good labs, sometimes errors can happen. Now, understanding W for wild type status, the absence of mutations are also clinically very, very important. Now, in the case of colorectal, if there is no KRAS, NRAS, so that means it'll be wild type, there's no mutation, there is anti-EGFR therapy. So sometimes you see that NGS report and say, we got nothing out of this. No, you didn't get nothing. Sometimes wild type status can be beneficial too. Or you say my patient had a KRAS, the KRAS disappeared. We in fact had a case recently where it was a colorectal cancer case. Patient had KRAS, it suddenly disappeared. And it was like, oh my God, we've lost a possible target. You haven't. You've actually gained the option of coming in and, getting a new target where we know that the response to EGFR, what we call anti-EGFR therapy, like cetuximab, panitumab, is any day better than maybe a MEK inhibitor for KRAS. While that sometimes is good. And look out for structural changes, those copy number changes, that are very, very important in our treatments, especially with your METs and your ROSs. We do tend to see a lot of this. Y is for yield for the patient. I think I mentioned it last time also in my talk that when we are doing NGS, one is obviously therapeutic, but a lot of times these genes have prognostic information. Sometimes they're hinting at what chemotherapy could be better. So when we are reading these reports, think about the end person, which is your patient. How does your patient practically benefit from this? Can you change chemotherapy? Is there targeted therapy? Is the tumor giving you any other hint? Based on that, make your clinical decisions. And most importantly of all, Z, zoom out. And I think that kind of A to Y together, zoom out. you have to integrate NGS with histology, with imaging, with the clinical story, and then look at the overall picture before making any clinical decisions. And I've discussed the A to Z, and I've obviously confused you because either they seem overlapping or it's a sense of how on earth are we supposed to do this? We barely get time with our patients. That's where the role of a molecular tumor board comes in. And I know Dr. Bhavna Siroi is going to be talking about this a little bit, I think tomorrow or day after. And that's where the role of an MTB comes in. A molecular tumor board are essentially a collection of specialists. So you've got your medical clinical oncologists, your radiation surgical pathologists, your research coordinators. You've got your genetic counselors, your molecular geneticists, molecular biologists, all of them working together in interpreting this report. So you are getting all the specialists in one place, looking not only at the report, looking at the clinical case, and helping you decide what is the right way forward. I can't stress enough how important these molecular tumor boards are. We run one at our center. So if anybody's interested, you can always send me a case and I can put it in our tumor board and come back with an answer for you. But I think one of my key learnings that today, if I'm able to put A to Z together, is because I have learned these from my colleagues from the molecular tumor board, and we all learn from each other. And because you're learning from each other, you're actually growing, and that helps you better interpret these NGS reports. And taking from there, I'm just very quickly going to walk you through some of the most common errors. And unfortunately, this has happened with us, and we have seen these in our clinic. So I'm not made these up. This is what we've had to deal with. I'm going to start with germline because at heart of hearts, I am a genetic counselor. So if I don't talk about germline in a talk, I feel very incomplete. So this was a patient with a strong family history of cancer, very classically Lynch. You couldn't be more classical, and comes back with this DUS. So I went back, like I said, I always check. I checked, and as per ClinVar, and then I checked some other guidelines, everybody's reported this as pathogenic. Went back to the lab, they argued, didn't agree. I said, you know what? Okay, let's rerun it. Let's send it elsewhere. It came back as being pathogenic. So check. First, I did a clinical correlation. Then I rechecked this case. And we went back and we confirmed it was. And then we tested the rest of the family. So everybody else had an MLH1 mutation. But check, double check. Now, this is a 59-year-old male. And I can tell you this case still gives me the shivers because, oh, this was a tough one. This was a 59-year-old male, hypertension, cardiovascular diseases, no family history, no known bad habits, had potential cough. We did NSCLC, it favored an adenocarcinoma. So upfront, we did NGS. We also did PD-L1 that came back negative. The treating medical oncologist sent this for, if you look at the top, oncomine tumor mutation burden NGS panel. Now this assay, this is why it, okay, so let me first tell you what happened and then I'll talk to you about what the errors were. So it came back that the TMB was low, 3.71, and these were the mutations we found. We found a RET and a TP53. Now, if you look at those percentages, they were really high, you know, nearly 60-year-old individuals. So because the VAF was high, the first thing was like, oh my God, let's do germline testing. First reaction. 2, let's give the patient selpercatinib. There's a RET. So that was a decision. The patient was started on it and had a really, really bad outcome. The patient came to us. So when I first saw this report, I was shocked that based on this first of all, I couldn't understand why this was, why this testing was done, because tumor mutation burden, this assay's role is to report tumor mutation burden. The rest of these genes that they report is incidental. So this is not my quintessential panel in actually reporting actionable biomarkers. So first things first, look at the test that was ordered. This was for the TMB assay, and this has resulted in an error. Now, second, go back and check these mutations. I checked the TP53. This does not have a germline variant. This germline event, it's an established somatic event, no indication of germline. Anyways, germline testing was done. This RET is a point mutation. Now, apart from 1, 2 that we tend to see in the medullary thyroid ones, which are frequently mutated there, apart from that, it's only RET fusions where we give selpercatinib. So I went back to check this RET mutation. Obviously, the Pandora's box was open. It's so high, it could be germline. So we had that chaos happening. So I went back and checked this RET mutation. Now, if you see over here, this RET mutation is likely benign. I said, all right, let's check somatic. If you look over here, it's benign here too, which means this RET ideally should not have been reported. So, like I said, the patient did all of this, complete mess. Germline was negative, very quickly, progressed. It was rapid progression, it was really unfortunate. Then at this point, we repeated the genetic test. We repeated the test. We took a new biopsy from the new metastatic site. That old tissue was exhausted. So I said, okay, let's send it for CGP testing. And guess what we found? Such a classical EGFR exon 19 deletion that was missed out. And I thought that was really, really sad that it was missed out, that this patient could have easily started upfront on an anti-EGFR therapy, a TKI, and unfortunately, we lost a couple of months here. Second, what I found interesting is, remember I told you the NGS report talks to you, there's a TP53 and an RB1 deletion, which means and we tend to see this usually when you have EGFRs, that maybe going forward, not necessary, there could be a potential histological change, which means it could go from adenocarcinoma and it could go to small cell, what we call a small cell transformation. So we've now put this patient on afatinib, on osimertinib, and so far so good. There's no histological change as of now. So far so good. Now, here's another case. Errors can happen with everyone. So in this particular case, this was a case of a sarcoma, if I'm not mistaken, and we found this NTRK point mutation. It was kind of surprising where this point mutation came from. And then I looked at the VAF and I'm like, wow, 99.9%. So my brain went, and I know I am a medical geneticist by training, and I'm like, oh, this could be a case of SEPA. This could be very rare. So my brain was very excited. I said, okay, this is something rare, something unique. There's a sarcoma. There's, this could be potential SEPA. And I went into this complete, I went down the rabbit hole looking for things. I was just looking for more information because I thought this was such a unique case. But my first thumb of rule is always check your mutations. When I checked this mutation, I even checked it on OncoKB. This actually came back as being, first of all, germline-wise, it was benign. So before I could act on that, it was benign. And then when I looked for somatic on OncoKB, I realized I missed putting that. It is actually a benign mutation. So this was actually an error that had happened. So when we wrote back to the laboratory, it was an error. It was a genuine error. So while I got very excited it could be something else, I had to go back to my rule, which is D, look at your databases. So irrespective, the reason I've highlighted this is that irrespective where your report is coming from, check, double check, quadruple check. Very, very important. Now, here's a case that taught us. I know I showed it that day, but I'm going to repeat it again for those who are hearing me for the first time. This was a young woman at the age of 59. She was diagnosed with ovarian cancer, no family history. So she underwent the normal testing. This was back in 2017. Then in 2020, she had a relapse, and it was again high-grade serous ovarian. So this time we sent it for NGS, and we found a BRCA1 mutation and a TP53. Looking at the VAFs being high, we went back and checked the databases. This TP53 was not a somatic event, but this BRCA was a potential. This TP53 was not a germline event, but this BRCA1 was a potential germline. And it was so difficult breaking this news to her. She was already upset that the disease had come back. And then to tell her, hey, guess what? This is a potential germline. Extensive counseling. We worked with the oncopsychologist on this because she was depressed. She has young children, and obviously, it's difficult breaking it at that point. And it came back as being positive. It was germline. We did Sanger testing. It was confirmed. And what followed from there, the guilt, and there was so many psychological implications that came in that we made it as our rule of thumb that if the patient does not get routed to a molecular geneticist or a genetic counselor upfront for for understanding somatic testing, the treating doctor would explain this and highlight that germline events are a possibility that can be picked up in these NGS reports. So just a learning, and that's why I've put G for germline events, because we have been burnt in the past here. This was an eye-opener. This was a 60-year-old male, no major comorbidities, known case of intrahepatic cholangiocarcinoma, was started on the very classical GEM-CIS, and around that time, the NGS was also done. The PD-L1 came back negative, and we did NGS, and we found an FGFR2 fusion. So we found the ACPP FGFR2 fusion, and the patient was started on pemigatinib because we were so excited. Yay, you found we found a fusion partner. So the MEDONC started the patient on pemigatinib, and within 2 months, there was rapid progression. So they stopped chemo and they started FGFR2 inhibitor. When this rapid progression happened, the patient visited the clinic. Obviously, when progression happens, they change doctors, they go somewhere else. So this patient lands up in the clinic. And when I saw this, the error that was here was the fact that with FGFR2, the orientation. So fusion is not about just finding a fusion partner. First is, in what orientation is it? FGFR2 has to be in the 5', and its fusion partner has to be in the 3'. FGFR1 and 3 aren't like that. They can go either ways, but FGFR2 is always in the 5'. If it's the other way around, in just 1-2 very rare cases, has it worked? But otherwise, rule of thumb, it's not going to work. And the reason is the TKI domain is not intact. If the TKI domain is not going to be intact, how is your drug going to go and bind? So the reason this patient failed in 2 months is because this was actually not an actionable fusion partner. So just because we see a fusion and we get very excited, and I know we all do, I know in 17% of these intrahepatic, we do tend to see FGFR2 synonymous with it. Please check your fusion partner. So these are errors that we do tend to see, and these are things that we're learning along the way. So to sum it up, how do I interpret in here? And again, this is just my learning. It's not the right way. I don't think there's any right way, but this is just what I do. I always like to start by understanding the history of the case. I will always go back and ask the MEDONC, or if the patient's directly routed, I'll understand the pathology, I'll understand the treatment responses, any past therapies, any comorbidities, any past history of any other cancer, any allergies, resistance, toxicities to any particular medication. So I will take a very, very detailed report. A lot of times I will also look at the PET scan to understand, is there a particular site in particular where it's not responding? Is it responding in the primary or in the metastatic sites? All of this helps me understand going forward, how do I want to treat the disease? Or how do I want to make a treatment recommendation? So once I've done all of that, I will be looking at the list of the genes. I will be looking at the VAFs, obviously. I am going to be looking at databases, have they checked for everything? And once I have a full understanding of the mutation, is it a loss of function, gain of function? How does it really impact? Is it something actionable? I will look at the pathways. Like I said, I will write down next to the gene, what pathway does it belong to? I look at that picture of the various pathways and try and understand the potential crosstalks, and I will start analyzing it. Once I've done that, I will then see, number one, is there anything I can recommend based on the guidelines or standard of care? Has everything been exhausted? Is my patient had any platinum sensitivity? Does my patient respond well to antifolate agents? I will try and extrapolate all that information and then start understanding, should we just stick to the guidelines? Is that going to be a better treatment option for the patient? Or is it going to be something, based on the pathway or the particular mutation? Or do I have to look at some combination approach? Well, these are just a couple of things that I look at when I'm interpreting a report. And while I'm doing that, putting all these molecular therapies together, please remember, a lot of times we're going completely out of the box. We may not have clinical evidence. It may be theoretical evidence. It could be based on some practicality that we tend to see. Maybe you're at the end of the road, it's worked in one particular tumor. You're like, okay, let's try it in this particular tumor type. But while you're doing that, here are some of the critical factors you should look at. That is my patient's performance status okay for me to recommend a particular drug? Because guess what? Even you as a molecular geneticist, when you're making these recommendations, you can't always turn around and say, oh, I'll just leave it to the medical oncologist. You can't, because the medical oncologist and you have to work in sync. You have to understand the performance statuses, the comorbidities. Is your patient a transplant patient? Immunotherapy is out of the question, right? So all these little things are very, very important. Talk to the doctor and understand from the medical oncologist. It's always... You cannot be sitting in silos. You have to work together. If you're not taking it to the molecular tumor board, there is every day, I can tell you in my OPD, every day there's a live molecular tumor board happening between me and the treating oncologist. And that is important because you need to work together in ensuring all of these, sub-points, these factors are brought into play before you make any recommendations with respect to molecular therapy. And to end this, I'm going to walk you through 3 important cases and kind of try and weave everything together. 65-year-old female, non-smoker, known case. She was diagnosed with NSCLC upfront. Tissue testing unfortunately failed, and then we went ahead and we did liquid biopsy. So I'm not trying to advocate liquid is better than tissue. These just happen to be in these cases. So I just want to put that disclaimer. So upfront, we found an EGFR classical exon 19 deletion. Patient was started on afatinib. And once the patient was started on afatinib, after a year and a half, the patient showed signs of progression. So patient was like, why should I do a rebiopsy? Liquid worked the first time, let's do liquid. So we went ahead, we did liquid. And the liquid, or this NGS by chance, picked up EGFR T790M. We know it's a common resistance mutation to exon 19 deletion. So we were looking for this, to be honest. So we went ahead, we did this, we found EGFR T790M. Patient was started on osimertinib, did phenomenally well for 3 years, and now the patient was progressing. Now, after 3.5 years, when the patient started to progress, we started thinking, what are my potential resistance to OSI? It could be C797S, it could be BRAF, it could be a MET amplification. So in my mind, we were already ready. In my mind, I was very clear that it could be these. I don't think there was going to be a major clonal change because if you see here, my original clone still existed, the exon 19 deletion. So I didn't feel that there could be a complete oncogenic driver change, but maybe a resistance. And that is exactly what happened. We acquired a BRAF V600E. We lost the T790M. The baseline EGFR, which was there from ground zero, from the time of diagnosis, was persistent, but we acquired a BRAF V600E. Multiple treatment options were there, and we opted for OSI with a MEK inhibitor because, and why did we not do Debra with trametinib? Because we do know that my original clone, which was there from the time of diagnosis, the EGFR 19 deletion still existed, which means somewhere it was still the driver, and it was the BRAF V600E, which was coming in interfering. So because BRAF V600E, if I look at that pathway, if I block with a MEK inhibitor, I'm shutting down that pathway. In an ideal case, you'd want to do BRAF. You would want to do Debra, trametinib, and your osimertinib. But I can tell you that's very toxic. Patients cannot tolerate it. So we said, okay, let's not go crazy. Let's do OSI with MEK. Or we had these other options as per the guidelines that were also available. So that's where we, slow and steady, over a series of 5-6 years, have actually treated this patient. And we've kind of preempted what to expect. Now, this is a 68-year-old female, CA ovary, stage 3C, clear cell ovarian cancer. Now, when we see CA ovary, the knee-jerk reaction is BRCA, HRD testing. This patient can get PARP inhibitor, but take a step back. Look at the pathology. This is clear cell ovarian carcinoma. Clear cells are usually synonymous with ATM mutations. So at this point, there was no family history. We had sent for germline testing also because we've learned that a lot of times patients may not have a family history but could carry a potential germline. So we did send germline testing. Our somatic report also came. And what you see over here is the ATM as expected. We also saw this in the germline, but we did an HRD test, and the HRD was high. But here's somewhere where the tumor was talking to you. In the HRD, before giving a PARP inhibitor, if you look at this, you have a CCNE1 amplification. CCNE1 amplifications actually confer to a certain extent resistance to PARP, because what they do, they make the tumor going from HR deficient, which means homologous recombination deficient, to proficient. So if you see a CCNE1 amplification, tread with caution. And we know our ATMs anyway don't do well on PARP inhibitors, but tread with caution. Another thing that was here is that PPP2R1A. These are usually associated with aggressive diseases. So you see, sometimes the biology can be very important, and obviously histology is important, and it's based on that histological classification I was actually able to interpret this report. And this is my last case of a 38-year-old female, IDC, metastatic breast, hormone positive. So she underwent first-line treatment and then progressed. So at this point, the question was, an NGS was done upfront. They decided to test based on NGS. So we had various options. If you see, there was an NTRK fusion also that was detected over here. So the question was, should we do standard of care, or should we go for the classical CDK4/6 with AI? And that's exactly what they did. They said, we're sticking to standard of care. Let's do CDK4/6 with aromatase inhibitors. They're not wrong. It's a standard of care. So we went ahead, we treated the patient with that. Within 4 months, there was progression. So now the question came, what do we do? So at this point, we went back to the NGS report and we said, look, we have an agnostic marker. We have this NTRK fusion. Let's consider treating with the NTRK fusion. And one of the biggest clues that we missed over here from the first slide was, in non-secretory breast cancers, in 1 out of 4 of them, they will have an NTRK fusion. So I had an actionable biomarker upfront at the time of diagnosis, which we very conveniently ignored because we jumped in to do standard of care, not realizing that this was the biology of the tumor. So based on the histopathology, your NGS was telling you that I have this option. Your pathology was telling you I have this option, and we missed it. We did put the patient on larotrectinib, and so far so good. But yeah, 1 out of 4 of these patients in non-secretory breast cancers will have a fusion. So that was an error. And we actually learned from it that, all right, next time look at the pathology, even in your breast cancers, where we're so tempted to stick to standard of care, you can be missing out on potential targets. And I'm going to stop here. I think with interpreting NGS, it's as long as you remember the ABCs of it, I do think slow and steady, you will start to learn to read these reports well and eventually be fluent with them. So on that note, thank you very much for your patient listening. I'm very happy to take any questions if there are any.
So thank you very much, Aparna. And I had requested Aparna to go slowly, take us through A to Z of how to interpret a report, because just before her presentation, she shared her slides with me, and I saw it is very important for people to know. I think devil is in the detail. And any of these things, A to Z, you miss it, if not in that patient, some other patient, we will have a problem. And that is something which is avoidable. So what she took you through a very systematic approach so that you don't make a mistake. That is very important. And remember, what is the A? This is talking of somatic testing. A stands for actionability. You are trying to find something on which you can act upon. So that is very important. And I think that should not be missed. From the comment questions that I have, I'll just, I'll summarize. One person has asked, what about labs using TSO 500 assay, which is, I think, the TrueSight Oncology 500.
That's right.
Panel. It is a RUO, which is research only, research use only, and people use it for clinical testing. Then someone has asked, what should be the ideal panel size for reliable TMB score? And someone has asked, can we just do a RNA-based analysis, or is covering DNA is also important? So these are some of the questions. I think before I ask Aparna to say, I think it is not just what panel has been used, which lab has used the panel, what is their workflow, and someone has also asked about accreditation. You may even have an accreditation, but accreditation for which test, how they do it, how they report. Most of the times in the report, I think once you have read 8-10 reports of that lab, you would understand. I'll end that with one more question. So you, Aparna, and anyone, when we talk, we show cases where we have found something or missed something, because we are trying to teach and drive home a point. But the fact is that in many patients we don't find anything. And generally, many of these patients, they would have been tested outside. Someone else would have done a testing. Now the patient has a recurrence. They come to you and they ask you, what shall we do now? So in that setting, how do you deal with that? How you take into account what test was done previously? And now after say 3 months, 4 months, there's a progression. So in your clinical practice, how do you integrate that? What was done earlier and what you would suggest now for somatic testing?
So I think it all boils down to what was done first. What was my assay? So a lot of times upfront when NGS is done, we don't start with something broadband. We start with something small, something which are those hotspot panels. So I would spend some time reading that initial NGS report, understand was everything covered? Is there something missing? I would do a clinical correlation. I would try and understand what is missing, where is the lacunae in all of this, and then from there I would make a decision that, okay, you know what, at this point I'm going to be looking for actionable biomarkers. I'm going to be looking for prognostic markers, because sometimes those prognostic markers are actionable in their own way. Then at that point, we will make a decision as to what testing has to be done. A lot of times what happens is at baseline, there is a smaller panel done, and then we do a bigger panel later on, and the patient go like, oh my God, my tumor's become worse because so many mutations were picked up in this and not in that. No, that's not true. That panel did not have it. So actually having a conversation and counseling your patient step by step, and especially upfront, what I've seen works is that before they do somatic testing, if I'm able to walk them through everything over there and help them understand what to expect, it makes a difference in the overall outcome of how they also interpret it and how they find it easier in understanding. But I hear you, we do tend to see between the baseline and now having an error. It does happen. Sorry. And coming to some of the other questions, I think everybody had, no, you cannot just do RNA sequencing. RNA sequencing in particular is for fusions. You do need DNA for your point mutations. You do need DNA for those frame shift deletion mutations, your deletions, duplications. You do need DNA. So it has to be a combination of DNA and RNA. I do know some labs are using the TS500 that, if it's validated, I know it's predominantly for research, but if it is validated, if they have good validation study for using it in somatic, sure, why not? And I think there are only 1-2 labs in India that actually have good validation data on that panel. So go back and ask for the validation and see how many. And validation doesn't mean 5-10 samples. A lot of laboratories do a significant amount of 50, 100 samples where they validate before they bring it into clinical practice. They do send it out abroad for EQUAS testing. There are, horizon controls that get used. They send. So there's a lot that is happening, but you just have to make sure it's not some 5-7 samples that they've sent for testing and they've validated it based on that. So ask for the data, ask for the sample set. In addition to that, the question was with respect to tumor mutation burden. It should be on a minimum 250 gene panel. Ideally, it is done on a whole exome sequencing, but due to cost constraints, we can do it on a 250, 300 gene panel is a minimum. 100 gene you cannot report. And if someone is reporting it, go back and check. So sometimes it could be using the exome and reporting based on that and just reporting 100 genes in that. So sometimes everyone uses the exome as the main panel, and then from there they just report accordingly. So sometimes these little jugaads do tend to happen. So be a little careful of that, but it should be on a minimum 250 gene panel at least. Have I answered all the questions?
Yeah. I think you have answered all the questions. I'll just narrate a story. When counseling, even for somatic, is important. a patient who had young man who died of sarcoma. Few months later, his family came and his father was narrating that how a strapping young man he died. But then he said, but that had to happen. All his genes were wild. His KRAS was wild. His P53 was wild. So I think, someone would have just told him it's normal, but they go back and read the report when nothing is working. So see, wild, a common person will think wild means aggressive and, it will be this thing. So I think counseling is very important. Even when you're telling about patients, do read the report. They Google, they do not know you're talking of somatic and not talking about germline. They don't know wild type means normal. So I think, people whosoever deal with them, the lab people don't have to deal with the patients, but sometimes even lab people have to deal with the patients. So I think that's very important. Putting it all together, actionability for the benefit of the patient. I don't know what was B for you. B was biomarker or something.
Biology.
Biology. Okay, so biology and benefit. So there's a term known as clinical benefit.
Yep.
People define it whichever way they want to define it, but ultimately that's the purpose of doing that. And it's an evolving field. I think 5 years, 10 years from now, how somatic testing would be done, I possibly can't be sure how it will be done. It will be done very differently. And VUS, you should ignore. I think that point she emphasized. Okay, in a germline setting, VUS sometimes, because in case it turns to be pathogenic, then for that person, for the family members, even if that person has died. But for tumor at that, because there you want in the next few months what you can do for that patient. So, today's session has lasted 1.5 hours, and but it's good. Aparna for 1 hour, 5 minutes, 29 minutes. But I let her speak because I think it's very important. All those. So that's all right. So thank you very much, and we will end the session today. Someone, just 1 second. Yeah, this Dr. Purvi Purohit. Thank you, Dr. Aparna, for a very crisp and detailed. Your examples, including both errors and breakthroughs, really are eye opener. So I think we learn from wise people learn from others' mistakes. Normal people learn from their own mistakes, and I won't say what fools are. They don't learn from their own mistakes. So so I think that is what we should be. We all make errors, and I think we should be humble enough to realize that we make errors. And Dr. Omshri had talked about the pre-analytical errors.
Exactly.
Yesterday, Dr. Prateek Chandrani said during the analysis, and finally, whatever it boils down to you. So you have to read each and every line very carefully, and you have to sniff an error, and
Yeah.
then you get it. Thank you very much.
Thank you. Sorry if I bored people, but I just realized.
And there's a public demand that during the 12 sessions of each tumor type, you have to be there for each one of them.
Done.
Okay?
Done. All right, I'll see you.
Please close the meeting. Thank you.